Good morning, and thank you to HCC for giving me this opportunity to give a presentation here. I'm from Tanzania Diabetes Association, based in Dar es Salaam, Tanzania, and I'm also a member of the World Diabetes Foundation Board. So in my presentation, I'm going to initially show you what WDF is doing, and then after that, we'll give you an example of what we have been managed to do in Tanzania with the National Diabetes Program and National NCD Program. And this will be sort of a presentation which is going through the whole process of how we manage as the Tanzania Diabetes Association, as a civil society, and a Tanzania NCD Alliance to get the national program going. So World Diabetes Foundation is basically based in Denmark, and it has been established by a foundation from Novo Nordisk in year 2002. The funding base is confirmed till 2024, and it might go for further extension. And the foundation gets approximately 15 million USD every year from the Novo Nordisk. The legal status of this foundation is that it is for combating disease, and it serves the social and charitable purposes, and it is actually registered in Denmark as a civil affairs agency with the civil affairs agency in Denmark. It is an independent structure away from the pharma company, running as an independent foundation. It has its own charter, it has its own statutes, it has its own board, and it is a secretariat. The mission of the WDF is to alleviate the human suffering related to diabetes and its complication, and among those least able to withstand the burden of the disease. Usually, it looks at the funding for the poverty based on the poverty focus, and it supports only projects which come from the low and middle income countries, which are in the OECD or the dark list. The proposal is based on the demand driven. It is based on what the needs of the country or needs of the association of an organization within the country are. And usually the preferred choice for the long-term sustainability is that there should be a partnership with the Ministry of Health to sustain a long-term sustainability of the programs. And as you know, from the burden of diabetes, as Professor John Errol Morrison mentioned this morning, you find that basically the rate of diabetes prevalence as per the IDF Atlas are going up very, what you would say it is going more than what was expected and what was projected. And usually the countries in low and middle income countries are significantly affected. Currently, the World Diabetes Foundation portfolio, it has done projects in 535 country projects have been done, out of which 239 projects are active. It has worked in 116 countries, of which 80 countries still have an active projects ongoing. The total funding since it started the program is US dollars 137 million, and it mainly works with the Ministry of Health, international organizations, civil societies, and associations. It has got more than 30 national programs which are directly working with the Ministry of Health and national health authorities on developing the national diabetes and NCD programs. And as you notice here on this graph, while originally the World Diabetes Foundation, the focus was on diabetes, and over a period of time, the strategy has evolved whereby in addition to diabetes and its complication, there's an inclusion of other non-communicable disease related to it. And now we are looking at a strategy whereby it's the integration of the non-communicable disease within the health systems, and not only diabetes, but diabetes as an entry point with the integration into the NCDs of the health system. And probably we're looking also, probably the future is the universal healthcare and health access, and how do we build the health system which can actually respond to the UHC. So moving from the WDF, I'm going to give you an example of what has happened in Tanzania over a period of time since we started with the first program in year 2003. So the background here is that the Tanzania Diabetes Association basically started working in year 2003 with the Ministry of Health and with the various donors. And initially, the donation was from the World Diabetes Foundation, from the World Partnership Project of Novo Nordisk, and then there were individual donors and Handicap International and EU, whereby we received some seed funding. The Ministry of Health, we worked with the Ministry of Health, who provided us the infrastructure, human resources, and the clinic space. And we as an association, with the professional groups, we developed the curriculum for training. We did the training component. We provided the tools under these grants. We established the association branches in the different regions and the districts. We put in the monitoring and evaluation system and looked at the supply and logistical system so that we could have a sustainable quality diabetes care in the country. Our partners included the National Ministry of Health, the University of Dar es Salaam, MUHAS. We also had National Institute of Medical Research and Association of Private Health Facilities and the church-based hospitals. In the international groups, we had the International Diabetes Federation, the World Diabetes Foundation. We worked with DANIDA. We worked with the EU, Novo Nordisk, Handicap International, and Lilly. And these are all the partners with which we actually implemented the program. And if you look at the timeline, we started in 1981-82. We had the first population-based studies which looked at diabetes in Tanzania. And this was basically the prevalence of diabetes at that time. In the rural population, it was less than 1%. In the urban population, it was less than 2%. And in 1985, Tanzania Diabetes Association was established. And we had the first opportunity to get some funding when we hosted the 5th Pan-African Diabetes Study Group meeting. At that time, we made some profit from that conference, and we started establishing the diabetes services. And we were part of the pilot project from the World Partnership Project, whereby we established small container clinics in the city of Dar es Salaam, in Zanzibar, and Pemba, trying to see how we can actually implement these programs. And we put in a 40-foot container because wherever we went to the clinics, they said diabetes is not a problem and we don't have space. So we said, okay, give us area for putting in a container. So we put in a 40-foot container divided into 4 rooms. The first room was for the nurses and the registration. The second room was laboratory and 2 additional rooms for the clinic rooms. So we started with those, and each of these clinics costed us around $8,000. And based on that experience we gained, we started applying for programs from the World Diabetes Foundation, putting in the regions and the districts. And finally, we came over to the National Diabetes Program, whereby we put in diabetes and NCD services in the 4 zonal hospitals, 27 regional hospitals, and 187 district hospitals all over the country. So what was the burden? Why did we decide to go for this care? So if you look at the studies which were done in the country, as I said, in 1981, 1982, in the population-based study, the diabetes was less than 1%, less than 2% in 1980s. And then we had the special groups, the ethnic groups, the Asian Indian groups was 9 to 12%, and 5 to 6% were usually in the parastatals, the chief executive officers, the members of parliament, and in the clergy. And you find that the rates were also extremely high at that point in the studies which were done in 1980s. And then we repeated the study in the same area in year 2000, and we found the prevalence of diabetes was 5%. And in 2012, when we did the STEP survey countrywide, we found the prevalence of diabetes was 9%, hypertension was 27%, and this was compared to the previously diagnosed population. So you find that in this 9% prevalence, we found that for every single diabetes who was known diabetes, there were 3 unknown diabetes. And in hypertension, again, we had the same figures. Other CVD risk factors, the dyslipidemia was around 15 to 32%, obesity was 12 to 36%, and in rural population, it was around 5 to 25%. Ischemic heart disease, we did not have much data because we did not have coronary angiography facilities, but based on the ECG and EKG finding, the rates were quite high. Stroke was again based on the previous incident studies which were done in Moshi. We found that the rates were quite high, and the gestational diabetes, which was done in 2013, we found that the gestational diabetes in urban population was 8.4%, and average population was 5.9%. So we started looking at and doing the needs assessment that what do we need to do within the systems, try to see that how can we combat these conditions which we have. So we started going to the clinics and started looking at the facilities which are available at the clinic, and how are the patients who are attending the already existing diabetes clinic, what were the service facilities being provided. So you find that in some of the clinics, the average in a patient going into a diabetes service, only 18% of them had an eye examination done. The blood pressure was measured in 76% of those attending. Weight was 73%. Urine analysis in 62%. EKG only in 8% of the diabetes patients attending the clinic. The renal profile and the lipid profile was done in less than 5% of those attending the clinic. Foot examination less than 10%, and dental examination less than 6%. So this gave us an idea of where do we need to actually strengthen our resources and try to see and what training component can we focus on so that we can start looking at these major complications which were being missed by simple testing. And we also started looking at whether we could actually go on to the HIV clinics, whereby we had an extensive HIV services there, who had all the biochemistry analyzers, they had all the infrastructure, whether we could use them to do these tests. We also started looking at, from the patient's perspective, we started interviewing the patients going to the diabetes services and what were their views. So most of them, 24% of them said that the clinics were irregular. When they went to the clinic, the doctor was not there or the nurse was not there. And 24% of them said that it was sometimes they went to the clinics, there was nobody to manage them. Then 61% could not manage the transport because the clinics were very far away. They were either in the zonal hospital or in the regional hospital. So traveling to those clinics was a major burden as a cost. 47% could not afford medication. 21% could not afford where they had to pay cost sharing for the investigation. 41% of them said that when they went to the clinic, they were being consulted, but they could not get any medications. And even if they had money to pay, the medicines were not there at the pharmacy at the hospital. And then 48% of them said that sometimes they had to wait for 4 to 6 hours before they could see a healthcare provider. So this assessment gave us an idea of how do we need to do the training and how do we do the basic facility. We also looked at if the patient had to pay out of pocket, where did the money come from? So 79% said they came from their own income, 13% had a social support fund, around less than 1% had some donations, 35% said somebody from the family contributed, 23% said they had to borrow money to get treatment, and some of them, 3 to 2%, this was a catastrophic spending, 3% and 2% had to actually sell their property to get well if they had the complications. So what were the interventions we did? We started, as I said, in 2003, we started training at the major zonal hospitals because our idea was that let's start from the top. If the top at the zonal hospital and regional hospitals, if we strengthen those facilities, when the referral systems come in, then probably their capacity to manage them would be right. So rather than bottom up, we started from top down. And we started, first of all, training the zonal hospitals and the main regional hospitals. And based on this experience, then we started looking at all the regional hospitals. When we started the program, there were 20 regions in the country. By the time we finished the program, there were 27 regions. Initially, when we started, there were 130 districts. By the time we finished, there were 187 districts. So we started with small programs, going slowly, learning from that, and then expanding. And looking at the regional hospital, the district hospital, we ultimately ended up doing the full complete national program, which included 4 referral hospitals, 27 regional hospitals, and 187 district hospitals. And when we started in year 2003 and 2005, our training was basically related to diabetes and its complications. But with the new global NCD movement, we changed our training material to not only diabetes, but diabetes and other NCDs. And we use this diabetes clinic as diabetes stroke NCD clinics. So basically, we covered the entire country with the diabetes services within the public sector. And in addition to that, we also worked with the church-based hospital, which were district designated hospital. And we also worked with the Association of Private Health Facilities in Tanzania, whereby they were also starting to train people in the private sector. So while we were establishing these services, we also noticed that there were a lot of children with type 1 diabetes which were being missed. And under the two programs, one was under the Changing Diabetes in Children, and the other one was the Idea of Life for a Child program. We established the diabetes services for children with type 1 diabetes. And here we started enrolling children under 18 years of age, and they were supported over 20, and they would get free insulin, free syringes, free blood glucose meters, strips, and they would have a continuous and a regular follow-up. And we basically enrolled when we started, we had 30 children. We enrolled about 800 children in 14 clinics. So we started training healthcare providers. And when we started talking to ISPAD, which was the pediatric endocrinologist, they said the clinical officers and the medical officers cannot manage children with type 1 diabetes. Now, when we started, we did not have a single pediatric endocrinologist. We said we needed to train healthcare providers, clinical officers, and nurses in managing these children. And that's how we enrolled with the program. And then after they were 18 years, they went into an adolescent group, and we again started having adolescent clinics in about 34 clinics all over the country. And over a period of time since the program started, we managed to train 7 pediatric endocrinologists to take care of these children. But still, the services at the regional and the district level are still taken care of by senior nurses and the clinical officers. So if you see now, we have started getting information about the children with type 1 diabetes. This is the diabetes registry for diabetes, and our peak usually is at between 11 and 15 years of age. And that's what we are starting to collect the data. At the same time, if you look at the HbA1c, when we started the clinics, it was more than 14. Currently, we are at around 9.6. The diabetic ketoacidosis incidence has gone down, and the mortality has also gone down. We also started creating the training curriculum for the different levels. So our training curriculum included cardiovascular disease, type 2 diabetes, early detection of cancer, and COPD. And we had these training manuals and case management training manuals. And we also converted this for the primary healthcare providers and the rural community health workers. We translated some of these booklets into the local language, Kiswahili, so that they could basically train and they could understand very well. At the same time, we also created a manual for NCD nutrition related to NCDs, so that they could actually talk about prevention and talk about diet and the nutrition and regarding the NCDs. So within each of these clinics where we established the services, they would get a height and weight scale, a blood pressure machine, a stethoscope, glucose meter, Snellen's chart, ophthalmoscope, measuring tape, monofilaments, and the tuning forks. And for the zonal hospitals, 4 zonal hospitals, as a main referral center, we provided them with an advanced foot equipment and advanced eye equipment so that they can actually follow up and manage all the complications. So basically the grant was between the World Diabetes Foundation and the Ministry of Health. We as a Tanzania Diabetes Association, we were the implementing agency. So we had an MOU with the Ministry of Health, and we used to implement the program on their behalf. And this funding was by the World Diabetes Foundation, and all the infrastructure, the human resources, everything was paid by the Ministry of Health. And overall, the goal was to reduce the morbidity and mortality and set up a national program. In addition to that, we looked at also the integration of the clinics. And when we did the training, we also trained healthcare providers from the reproductive and child health, from the TB and leprosy, eye and dental, and HIV/AIDS, because knowing that people who had HIV/AIDS, who were antiretroviral drugs, were also developing non-communicable disease. Also, eye and dental was a major, again, area where we could pick up people with diabetes and hypertension, TB and diabetes, as you know, and in RCH, basically reproductive and child health, to pick up the diabetes and pregnancy, at the same time gestational diabetes and hypertension and pregnancy. And we also trained nutritionists, and we also basically sensitized the regional health management teams and the community health management teams so that they could do an appropriate monitoring of the programs which are in place. And for the monitoring purposes, we use 5 tools, which was the community level awareness, the patient utilization, healthcare providers, healthcare facility, and a monthly report. So these were the monitoring tools which we used, try to fine tune the program. And currently now what we are doing is that after we have finished our regional and the district level, we want to go to the health center and we want to go to the dispensary level. So there are more than 2,000 health centers and more than 6,000 dispensaries. And what we are looking at is integrating care. So initially we started looking at a needs assessment and trying to see where was the gaps. So if you look at this facility, this is one of the regions. You find that antenatal care, delivery, immunization, family planning, HIV and TB leprosy coverage was more than 80% in a hospital, in a health center, or in a dispensary. But if you look at NCD and diabetes, the coverage was less than 20% in these facilities. Again, if you look at the education or health education being provided, again, you find that health education provision at different levels of these regions, again, was less than 20% related to non-communicable disease. So when we concentrate on, when we start rolling out a program at a health center and a dispensary level, then this is the component which we are going to emphasize on and press on. And we are working on a model where we have started a pilot of having at a health center and a dispensary a common triaging. We have a common triaging whereby a patient, when he comes to the health center or a dispensary, has a basically health education, a BMI, a blood pressure, blood glucose, a provider-initiated HIV testing, counseling testing, and TB screening. And this is a common triaging which is done. And based on the common triaging, then they would be referred to the specific clinics. So this is the model we are looking at. We are also looking at community health workers, looking at the screening camps, school health programs, and the workplace programs at the primary level. And we are actually, it is being done is to look at the cost effectiveness and the health index beneficial of how we are going to do it before we roll it out all over the country. So we have also partly been instrumental in forming the Tanzania NCD Alliance, which now includes cardiovascular, diabetes, cancer, respiratory, mental health, trauma, sickle cell disease, other risk factor groups, and the complication groups also. And we are now starting to look at basically rolling out to the primary care, trying to see and having an integrated care approach of a chronic care disease. Thank you very much.
Thank you very much, Dr. Ramaiya. Are there questions for the doc? Any questions? Yes, I want to go back to, I can do this. Go ahead.
Thank you. I just wanted to compliment you really on the initiative that you're taking, because a lot of times sub-Saharan Africa it's the thoughts is just communicable diseases. I remember teaching some MPH students, and I put up a graph where red was the highest rate of stroke globally. And it was in the old Soviet Union, and Africa had red. And I asked all my students, what disease is this? And they could not tell me what disease it was. Nobody could conceive that it was stroke that had these rates in Africa, because if you don't die of HIV, you have undiagnosed hypertension and you die of a stroke. So a lot of work to be done, and just wanted to compliment you.
Yeah, thanks for that interesting model, because one of the challenges we have found, we implemented a chronic care model intervention a couple of years ago, which focused on diabetes, and the majority of our patients have diabetes and hypertension, like 90% of those. So one of the criticisms from the field was, why we just looking at diabetes? We were able to do diabetes and add hypertension on. It wasn't necessarily explicit in the intervention, but we would need to address both when doing our clinic. So I really appreciate your presentation. The other part, though, I would ask, what about auditing and monitoring of care delivery? Because that's another gap that we found. So even though we train persons, they may not comply with the standards.
I think, thank you for that. As I said, when we started out, we started as a diabetes service. But if you look at our prevalence rates, prevalence rates of hypertension are very high. And inadvertently, 60 to 70% of the people with diabetes tend to develop hypertension, and then they start developing other complications. So that integrated approach was that now it is not a diabetes service only, it is an NCD clinic. And basically the healthcare workers are being trained on the multitasking, in a sense, having diabetes, hypertension, early detection of stroke, and early detection of cancer. And that is what we are now looking at. We are also doing the monitoring and evaluation. And in fact, we have an independent university group which is doing the monitoring and trying to tell us, because before we go to the next phase, we would like to know where have we gone wrong so that we can prevent. The biggest challenge we have is the attrition rate, because you train and people move away. So, yeah. So we have actually developed in the university, we have developed a 3-month certificate course on diabetes education and on this NCD education and NCD training. So we are actually now, and because they get a certificate from the university, they have also a career path, and they also tend to get promotion. So we start getting those healthcare workers coming for these certificate courses. So we have some sort of a continuous training program going on. Yeah.
Dr. Ramaiya, thank you very much for this, this exposition. You know, I've been saying all morning that I haven't heard anybody talking about capacity building in relation to NCD management. We can tell the patient only what we know. So I'm from Grenada. We have a fabulous population of 100,000 people on a good day. So we're the best study population on this side of the world. The truth is, recently, as part of our NCD, one of our NCD objectives, our plan, implementation plan, one of the objectives is to improve capacity. And I kind of come in for a lot of flack when I decided that I'm going to focus on training the people in primary care, because I don't really work directly with primary care, I work in the ministry, and there's somebody responsible for primary care. But this does convince me that this is the way we have to go. And more so, you have actually globalized your training and your screening, because we tend not to go into the maternal and child clinic looking for those cases. We just look for people who come to us. I think we should take this seriously into consideration, that persons with the potential for chronic diseases, whatever we want to look at that as, are in other places, including in our children or pregnant women, in the dental clinic, etc. Because those are where the gaps exist, and those are the people we might forget. So thank you very, very much for this.
In fact, for the eye clinics in one of the eye hospitals, 30 to 35% of the patients attending the eye clinic had diabetes, which was undetected. So similarly, for the dentist, when they go for the oral health, you find about 15 to 20% of the patients attending oral health had diabetes and they did not know. So I think it's an integration we need to give it. And those who are on HIV and antiretroviral drugs, after 4 years, they tend to develop the NCDs. Yeah.
Thank you for sharing the journey that you've been on and the evolution from the diabetes focus to a bigger NCD to going more upstream. Diabetes and NCDs are symptoms of the failure of our development paradigm. And thank you also for sharing the concrete work that you've been doing, the early work showing the unmet need. It reminds me of my early work in the UK, studying the quality of diabetes care and then in putting in place restructuring services to improve quality of care. And over that time, diabetes has just increased and increased. So the progression of thinking beyond just diabetes is ever so important. The rule of halves that doesn't really apply here so much, because with all awareness, the vast majority of people now actually know that they have it. The problem is when they get told you have a touch of diabetes, and then they don't attend any care for the next 5 or 7 years until a slight. And that is a disservice that doctors do to people. But thank you very much for sharing.
Thank you.
Thank you. We have one more question.
Right, so I've heard persons speak of the chronic care model as a useful tool, but After examining the model, I think that many of our primary healthcare facilities already have delivered over the years elements of the chronic care model. The chronic care model is nothing new to the Caribbean. And I think that if we look at our primary health care and how we deliver it, you will find that it will coincide with a lot of the features in the chronic care model. So I don't think that to say that you have implemented a chronic care model is going to suddenly change your outcomes. Thank you.
Thank you very much.
Yeah, and currently now with the Tanzania NCD Alliance, we are doing the training of the peer educators. Actually, we are using these peer support groups to actually try to train, go into the primary care and at the community level, and trying to see if we can get them to sensitize the community and also talk to their colleagues. Yeah.
Thank you very much. Kenneth Connell, Barbados. I know we're out of question time, but this is a very quick outcome for this forum, that all organizations and associations involved in diabetes care and management should see as their central focus hypertension as well, because it's the driver for death in diabetes, and this is a concrete outcome that can come from this forum. Thank you.
Thank you. We're out of time for questions. We're out of time. We're out of time, really? You really, is it burning? Burning? Oh, so, there's another burning, so she has spoken, so.
I think it's important for us to look at integration of all of our services when it comes to chronic diseases, but also that when we speak to integration, that we don't focus just on integration of the service areas, but integration of the registers and the data sets that we collect for those areas. And for our countries where we don't have electronic systems and where we still rely heavily on a paper-based system for collecting information, how that integration can translate in the data collection as well. And I think one of the questions that I've wanted to ask since Dr. Morrison's presentation, and maybe we can ponder on it and answer later, is how do we improve data quality and data availability in our countries, especially in countries where we have such small populations, and somebody else looking on the outside would say, if you have 100,000 people or 170,000 people and not 13 million, then improving data quality should be an easy task. But for the individuals on the ground who are actually doing it, then they realize that it actually isn't.
Okay, one last burning short question.
No, this is just a comment, and maybe you can share. We have talked a lot about traditional medicine, but we haven't spoken to a fact that in the Caribbean, many of our patients, and I think someone from Diabetes Association may be able to share, take a lot of herbs, supplement, other alternatives. It's a multi-billion-dollar business and industry in the region, but we have not spoken about that because most of them, some of the research has been done, most of them don't share that with their provider. Sometimes it's in conflict with their therapy, and some of it, there is science behind it. So how are we addressing it? Because if you talk about NCDs, you must address that component.
Okay,
I
thank you.
think it's a relevant question. In our circumstances also, we have got the traditional healers. What you have tried to do is that through the Ministry of Health, the traditional healers have to be registered. So we have tried to talk to them and tell them what is their level whereby they should be referring. And that's what the sensitization we have been doing. But sometimes it is difficult to change the culture.
Thank you very much, Doctor. Obviously, your presentation hit quite a number of issues that needed to be responded to.